Hello everybody, my name's Joanne Wright. I'm not sure if I've met all of you before, I don't think I have. I work with Louise in the support and information team at the Bone Cancer Research Trust. Just a few bits of housekeeping before we start. If you can keep your microphones on mute whilst Carol's talking, it just cuts down on the background noise. And also just to let you know, we will be recording this webinar so that we can upload it to our YouTube channel. So if you don't want your image to be uploaded to YouTube, just please turn off the camera. And there'll be an opportunity to ask Carol questions at the end of the webinar. The way that we do this is we ask you just to use the chat function to let me know that you want to ask a question, and then I'll then ask you to put it to Carol yourself at the end of her talk. And if you could keep the questions just to a general nature, really. If you have more personal questions that are pertinent to your situation, if you could contact us afterwards, we'll try and answer them for you. So I'll just pass you over now to Louise, who will introduce Carol.
Thanks, Jo. So we're really pleased today to be joined by Carol Hughes, who is a Macmillan counsellor at the Royal Orthopaedic Hospital in Birmingham, for our 9th support and information webinar like this. So we know that a cancer diagnosis can bring a whole new level to the word struggle, from the physical effects of treatments to the emotional and psychological effects that cancer has, not only on the patient but family members too. So today, Carol is going to be talking to us about the wide range of psychological implications that cancer has on patients and their families. So from when cancer is first raised as a possibility, dealing with the treatments, and arguably the most important thing, life beyond cancer. So thank you so much, Carol, and I'll hand over to you.
Hi everyone, nice to see some familiar faces and some new faces as well. And this is an unusual thing for me because very often I'm working one-to-one. So to work with a group is a rare pleasure, and that's just brilliant. So I have to go up here, don't I, and do share screen. Oh, there it is, it's at the bottom. Wrong place. So if I share my screen, so promise it won't be death by PowerPoint. It's lots of pictures and things, so not too turgid, I hope. So I thought you might like to know a bit about me to begin with. That's it. I trained as an integrative therapist because you know, no one therapy suits everyone. Everyone's different. And since I've trained, I've gone on and done other trainings, which you can see I've listed there. And I've also started training in another therapy called EMDR, which is eye movement, desensitization and restructuring, which is a therapy for trauma. And I suppose one of the things I want to say is that everyone is different. So as I'm going through this, I'm talking about common things and usual things, but they may or may not apply to you. So the things that apply to you, that's fine, and anything that doesn't apply to you, you just junk it if it doesn't apply to you. So first of all, you know, a cancer diagnosis, there's no doubt about it, it's a bombshell, and it has a far-reaching fallout. So it goes into all kinds of different domains, and most of all, it goes into the family. It's like having a hand grenade thrown into the family. And I think what's important to understand is that partners of patients with cancer suffer the same rates of anxiety and depression as the cancer suffers themselves. And depression tends to diminish. So 2 years after diagnosis, rates of depression in people that have had or are living with cancer are fairly normal, 11.6 as opposed to 10.2. And anxiety, which is also similarly very high at the beginning of diagnosis, actually, instead of diminishing, it tends to rise over time. And 10 years post-diagnosis, about 50% of people, you know, cancer patients and their partners will be suffering anxiety. And in fact, partners are even more likely to suffer with anxiety, 40% likely to suffer with it as opposed to 28. And I think that's really important. And I'm so glad to see some partners here today, because this presentation is for you just as much as it is for your partners. I work in something called the Biopsychosocial Model, which is an understanding of health, which says that the psychological, the biological, and the social are so inextricably mixed that it makes little sense to try and pull them out sometimes. I mean, obviously, the tumour has to be treated, and that's a biological event. But the psychology and the social sphere are so linked with what's happening biologically. And we owe this sort of division that we have in health, where we think of physical health and mental health as being different, to René Descartes. I don't know if any of you know, but he wanted permission to chop up bodies, so he persuaded the church that the mind and the body were different, and then he got permission to chop up bodies, and we're sort of stuck with the residue of that, this division into psychological health and mental health, when they are actually inextricably linked. And we know that the same areas of the brain that deal with the pain of social rejection are largely the same areas of the brain that deal with physical pain. And we also know that physical pain is at its worst when we're alone, and that the presence of another person will lessen that pain, and the stronger the relationship to the person that's present, the stronger that effect is. And there are common times to struggle. You know, we know that the diagnosis is a horrendous time. Waiting to receive that diagnosis is almost unbearable, and the actual being given the diagnosis itself can be pretty traumatic. And it can be traumatic enough in some individuals to actually cause full-blown post-traumatic stress disorder, where they get flashbacks to that moment and it's intrusive and they can't get past it. And you know, if that's happened to anybody or anybody that you know, then there are ways of helping with that, and in fact EMDR is one of them, but it's not the only way. End the treatment, which just seems like, you know, a strange time to struggle, but it's really common to struggle at the end of treatment, and I'll go into that a little bit more in a minute. Recurrence, obviously, when patients are told that their tumour is no longer curative, and we use the word palliative, and I sort of hate the use of the word palliative, really, because it's so synonymous with end-of-life care. It's almost like we need to find another term for patients that are living with cancer, because the kind of treatments that we have now mean that many, many more patients are living long lives with cancer, where episodes of cancer are being treated. And it's no longer like it used to be in the old days, where you had cancer, you were treated, and you were either cured and you lived, or you weren't cured and you died. And it's so much more complex now, and people, you know, live with cancer, and the treatments are evolving all the time. And of course, end of life, you know, that's, you know, there's a whole branch of psychotherapy, existential psychotherapy, which is devoted to the fact that actually we all live with this spectre of death at the back of us, and cancer brings it into the foreground, and that can be pretty traumatic, and especially if you know that you're approaching that time, and that can be a time when psychological support's really needed, not just for the patient but for everybody. So going back to why we find uncertainty so difficult, and why it seems to be underlying lots of the times when cancer patients really struggle. There was a beautiful little experiment devised in 2016 that illustrated the relationship between anxiety and uncertainty. Researchers got people to play a computer game in which they turned over stones, and if there was a snake underneath the stone that they turned over, they got a painful electric shock. Now, the researchers could actually alter the probability of there being a snake underneath. And what they found was, you know, predictably, that a low risk of translated into a lower anxiety state in the person playing the game, and a high risk for finding the snake translated into more anxiety. But actually the highest levels of anxiety of all were those where the risk was 50-50. And you can see how that works in a cancer setting. You know, have I got cancer or not? Have I got the recurrence or not? And so on. It seems that we prefer certainty, even if it's bad news, to uncertainty. The uncertainty is absolutely unbearable for us. So going back to the end of the treatment, in sarcoma, treatments are often really long and arduous, and this is a very common time to struggle. But at the end of all the treatment, that hoped-for day arrives at last, and instead of feeling amazing and celebrating the liberation, cancer patients often crash at this point. And I use the metaphor of a ship, and if your previous life was a ship sailing along happily, then cancer is the rocks upon which it crashes and sinks. And treatment is like the exhausting fight to get to solid ground again. And when you finally manage to drag yourself up onto the beach, bedraggled and depleted, and at last you feel safe enough to turn around and look at the ship going down, it's a terrible sight, the number of losses that you will have endured, and you grieve for your previous life. But then maybe you notice that actually all has not been lost. Some things are retrievable, and maybe you haven't lost quite as much as you feared, and you start the long process of recovery. And it is a long process. There's initial recovery where you get back your strength. That's the immediate post-surgery or post-treatment phase. And then there's a recuperation period where you're now strong enough to work at regaining function. And then comes the recovery where you actually, you know, you're building your new ship, your new normal. And that process can take anything from months to years, depending on the length of the treatment you've had and how difficult it's been and everything else that's going on in your life. But it's important to realise that you're not alone, and there is help out there. So your cancer nurse specialist and your GP are just great places to start very often to find out what help is available, and they can refer you to signpost you or refer you to services that you need. And Macmillan's amazing. I mean, not just because I'm a Macmillan counsellor, but I mean that my whole post was funded by Macmillan. My post wouldn't exist but for Macmillan. And they have all kinds of expert information, advice and support available, and practical things as well, like, you know, they're means tested, but if people need a fridge or help buying a mobility scooter or something like that, Macmillan will help. There are all kinds of expert information groups out there, and groups like this one, you know, is amazing. And I think these series of seminars that you're doing are just absolutely brilliant, priceless, I think. There's Limbless for people that have had an amputation. There's Shine for people in their 20s and 30s and 40s, because they have particular things that are, you know, particular to them, like premature menopause and so on. So there is lots of help out there, faith leaders, local authorities, although I think increasingly there's a cash strapped, it's harder to get help, but they, you know, but they often do still have benefits advisors and things like that. So there is help out there, and that's important to realise. So when is it time to ask for help in terms of therapy? And it might be, and I don't know if any of you have seen this distress monitor on the left. That's a screening tool that's often used in some cancer places. I think we used to use it, I'm not sure if we still do actually, but the nurses ask people to rate their distress. And I think a score of 4 or more would mean that the nurse would ask you if you need any help of any kind, and that would start a discussion. But there are also more subtle signs, so that maybe you've just simply been spending a lot of time feeling really low or distressed. And one of the first signs of mental ill health can often be that you're not sleeping so well. And maybe all the usual things that you've tried or your go-to remedies aren't helping. And you maybe feel unable to voice your feelings honestly to those that are closest to you. Or sometimes I often hear patients say they feel like they've worn out their family and friends, that they can't keep going over the same ground, and you need to maybe come and talk to somebody else. Or you might find that you're overusing or abusing something or someone. You know, alcohol is a common one, but it's not the only thing. Or maybe more subtly, people have just noticed that you're not yourself, and I've said something to you. So if you do opt for counselling, you know what to expect in a first session. Well, essentially, counselling is a safe space for you to talk about what's going on for you. And it's safe in a number of ways. It's safe because you won't be judged, not ever, for what you bring. And it's safe because what you say won't be repeated, not even to your clinical team. The only time that confidentiality would be breached would be if there were safeguarding issues. So if, for instance, you know, you were suicidal, or there was some kind of violence or something going on at home, then your counsellor or your psychologist or whoever would have to break that confidentiality. But it's really rare. And your therapist is there to, you know, understand who you are, to help you identify your strengths as well as what constrains you. And it's also an opportunity to learn new skills that you can use to help in your recovery. And all kinds of issues get brought to therapy. Sometimes it seems that cancer is the least of someone's troubles. And also people are more likely to be suffering from ill health if they've got unresolved issues in the past. And it seems like cancer can be like a crack in our defences, that the problems can manifest when you're feeling low. And we've heard for some time about an epidemic of loneliness amongst the elderly, and COVID has really brought that home for all of us. We're social beings, we're designed to connect, and if we can't connect, we suffer. So for anyone having to go into hospital right now, deprived of the love and support of those closest, it's been particularly hard. And also for those who are stuck helplessly at home and unable to give the help that they want and need to be able to give. So working out how to connect. I mean, I've been doing house parties with my family, doing quizzes and things like that, but you know, finding ways of being able to connect, and these kind of Zoom calls where you can connect with other groups are invaluable for that. And just finding the energy to do that. We might, you know, if we're low energy, it can feel really difficult, but reminding yourself of the importance of connecting. So what else helps? So, you know, these are some of the things that we're going to go through now. So acceptance, breath exercises, meditation, pacing, positive thinking, the role of the brain, sleep, social connection we just touched on already, and just understanding the journey. I think we've touched on a little bit already. So acceptance. Well, what is acceptance? Because sometimes acceptance gets confused with resignation or defeat. But actually acceptance is the realization that when we can accept things as they are, then we can let go of the various ways in which we sometimes fight reality. Then we can conserve our energy to use more productively and enjoyably. That said, acceptance of something you didn't want isn't easy. So mindfulness meditation can be helpful here, learning to let go. Likewise, acceptance and commitment therapy. But there are lots of ways, and just learning to let go of some of the stuff that you know may be holding on to. This exercise is absolutely brilliant, the 4-7-8 breath exercise. You breathe in to the count of 4, hold it for the count of 7, and breathe out to the count of 8. It's absolutely brilliant, and what it does is it slows down the heart. And when we're talking about the interconnectivity of the mind and the body, and when you slow down the heart, that sends a signal of calm to the brain. And it's absolutely brilliant for bringing down anxiety. It can also bring down blood pressure, because when we're anxious, what we tend to do is that brings physical tension into the body, and that physical tension sends up your blood pressure. So if you can learn to let go of the physical tension and let go of the anxiety, then recently he had dropped down to normal blood pressure for the first time in years, and he thought the exercise was so brilliant. He was teaching it to his wife, his granddaughter, his neighbour. I can't recommend this enough. It's something you can do anywhere. You can do it while you're driving. You can do it if you're waiting to be seen in the waiting room when you're feeling anxious. You can do it before a job interview. I mean, it's just a fantastic exercise. So coming back to mindfulness meditation, there's been a meta-analysis done into it, looking at all the research that was available, and it shows that it doesn't just reduce anxiety, it also reduces depression and pain. And even when it doesn't reduce pain, it counters the natural tendency that we all have, if we're having any kind of pain, physical or mental, for our awareness to sort of latch on to that pain, and for the pain to dominate the whole of our awareness. So what meditation does is it helps us to become aware of that and to introduce a space to let go, to stand back. And in that space, there's the possibility then of pleasure. And pleasure's such an antidote to anxiety. This is Vidyamala Birch. She started an organisation with 2 other people called Breathworks. And she's a long-time pain sufferer herself. And her courses are now available online. And this is one of the exercises that she teaches. It's not particular to Vidyamala, it's a meditation exercise, but it's called RAIN. So just remember an acronym. R is to recognise what's going on, to actually stop and feel what's going on in yourself, and then allowing it to be there, or accept it, you could say. And then to investigate it kindly, not to cross-examine yourself, but to sort of go into what it is that you're feeling with an attitude of kindness and softness towards yourself. And then the end, Vidyamala calls it natural awareness, other people call it non-identifying. So when you're feeling overwhelmed emotionally, it's to be able to step back from what you're feeling, and to be able to observe what you're feeling. And in that stepping back and being able to observe comes some relief. So this next slide I just put in for laugh. 2 monks meditating, and the younger monk asks what happens next, and the answer is nothing happens next. This is it. You know, meditation, you know, you're not going to levitate or see rainbows or anything else. It's just about being able to be with ourselves right here and right now. And actually being able to be right here and right now is really helpful with anxiety and depression. So this is quite broad brush, but very often depression is about getting stuck in ruminating about things that have happened. And anxiety is often about being sort of mesmerized by fear of what may happen in the future. And if you can learn to detach more often and to come into the present moment, and to know that whatever happens, you in fact only have to cope with it moment by moment. We don't have to cope with everything all at once, ever. And at the bottom of this slide are some of the courses that you might want to look for if you decide that you want to do a meditation course. I thought I'd do a slide on sleep because sleep's so often affected. I often see cancer patients who just haven't slept for months or not slept properly for months. And sleep's really important. I mean, the left-hand side of the slide shows that restricting sleep to only 4 hours results in a whopping 70% reduction in your immune activity. And you need your immune activity. The surgery, the radiotherapy and the chemo are all valuable, but you need your immune system. And in fact, the latest treatments in cancer are beginning to look at actually harnessing the power of the immune system, how to boost it, how to target it, and how to unveil cancers so that your immune system can actually do its work. So what helps you sleep? So if you reduce lighting late in the evening, that increases the melatonin, and the melatonin is a hormone that makes us sleepy. So also no blue light particularly, and blue light comes from smartphones, tablets, TVs and so on. And so an hour, preferably 2 hours, but at least an hour before bed, no blue lights. So turn everything off. Don't have your phone next to your bed unless it's an emergency situation where you need to be contactable. Get into the habit of putting your phone downstairs on charge and checking it in the morning, because the blue light will actually decrease the melatonin and make you alert. So you can sit up all night if you're playing a computer game, and adolescents often do. So warm milky drink, it's traditional, but it really does help. And a warm bath. So warm bath not only relaxes your muscles, which is relaxing in itself, but as blood is drawn away by the warm water to the periphery of your body, when you come out of the bath, that core body temperature, which has cooled, sends another important signal to your body to ready for sleep. Meditation can help. A warm bed in a cool room is ideal. So, sleeping with your window open unless it's absolutely freezing, but having a warm quilt. And most of all, a dark, quiet and safe environment in which to sleep. I think there's an increasing body of research now that just shows how bad light is for us at night. I even put a little black cloth over my clock alarm, so I can't bear the light from the liquid crystal display. So I'm a princess of darkness. And then, of course, sex is something that people so often don't like to bring up, but it's something that's often affected by cancer, particularly if you've fallen into the roles of patient and carer. And what's really helpful, and for most people, it will sort it out, take sex right off the agenda completely for at least 3 months, and just work on recovering intimacy, being able to get into bed together and cuddle up without worrying about sex and whether it will work or not. Maybe massages, things like that. And then if you're still having problems, you don't need to suffer in silence. Get your GP to refer you for some specialist help. And positive thinking, which positive thinking is known to be really helpful, but just telling people to be positive is such a waste of time. In fact, I think it's even counterproductive. It's just one more thing to be failing at. Because sometimes people need first, to honour the difficult emotions that they're experiencing, like grief or anger or anything else that might be troubling them, before they're ready to allow themselves to hope and to be positive. Maybe even to look at what this difficult time has given them. So on the left-hand side of the slide, you can see that's the Japanese art of kintsugi, which I think is absolutely brilliant. I'm not sure if it might be kintsugi, I'm not sure if it's a hard or a soft G, but it's an art in Japan where when a pot is broken, they mend the pot with glue and then they pick out the cracks in gold. And I think that's such a beautiful metaphor for recovery. But, there are lots of metaphors and lots of stories that engender hope and help people to move naturally to a place of being more positive rather than having it laid on them as another thing they ought to be doing, along with the kale. So, and another helpful phrase, this comes from CBT actually, a thought is not a fact. And that speaks to the incessant internal commentary that we all suffer. It's the human condition. And it's known, this internal commentary is known by some therapists as the shitty committee. We've all got one. The Buddhists call it the monkey mind. And, you know, you all have that sort of the anxious mind leaping from thought to thought, anxiety, criticism, maybe full-length horror movies starring you, produced by you, based on concept by you, in glorious technicolor running in your mind. So we need to notice when our mind's doing this, you know, not to, those thoughts can be so sticky, we can be totally enmeshed in them before we notice that we've been carried away by them. So we need first to learn to notice that that's what our mind's doing and recognize what our mind is doing for what it is. It's producing anxious thoughts and they're not the truth. If only we could be more like the zebra that's managed to outrun a predator. And initially the zebra will lie down and shake as its nervous system resets, and then it will resume eating. It won't torture itself with all the what-if thoughts in the way that human beings do. And probably one of the most important things that anybody recovering from any kind of health condition needs to learn is pacing. So we need to be able to step back from our previous standards and what we used to be able to do and what maybe our mind is telling us we should still be able to do. And we need to tune into our bodies more. And the temptation is always to listen to the slave driver mind and to try and do too much. And this temptation is especially acute when we're having a good day. When we're having a good day, we try to do everything that's been frustrating us that we haven't been able to do. And this is a mistake. We get overtired and this is almost always followed by a bad day. And this becomes a pattern when we get into this boom and bust cycle that you can see here, which is like a, you know, roller coaster all of its own. It's worse than just cycling, that the cycles tend to become tighter and tighter. And that's increasing fatigue, increasing pain, or increasing depression, but we spiral downwards. So learning to, you know, relax our standards, and tune into our bodies, and to be able to not to do too much on a good day or too little on a bad day, because that's the other temptation, to have a complete duvet day. And to try not to do either of those and to steer that middle path between the rocks. Think of energy as being like money. You need some in the bank. Don't use it all up. And the other thing that we don't often talk about, and it's not appropriate when you're going through treatment, but later on as you're reviewing what the whole cancer experience has been like, is that there will be gains as well as losses. And if your life is a ship, going back to the ship metaphor, maybe the ship that you rebuild will be sleeker and carry less baggage. Children and young people often experience a sort of accelerated maturation, and they wonder why their friend is so upset by the spot on the end of their nose. And likewise, adults often experience post-traumatic growth. Their priorities change. They no longer sweat the small stuff in the same way, and they have a deeper appreciation of what and who it is that they love. And those are the good things that come with having cancer. A picture of, that's my partner actually, with a load of cushions on him. That was an exercise that Vidya Mala does, and it's a really moving exercise actually. She gets someone to sit down, and whatever their condition is, she asks them to say all the things that they've lost because of their condition, and with each thing that they say, she puts a cushion on their lap. And this is what often happens. The cushions pile up and pile up. until the person can no longer see the rest of the group, and the rest of the group can no longer see the person. And I've seen people cry behind that pile of cushions or watching the pile of cushions because it means so much to them. There are lots of losses, and they do need to be honoured, and we do need to look for the gains as well. It's a very mixed bag. So if you take anything from this presentation, I'd like you to remember that you're not alone, that there is help out there and support. There are skills you can learn, things that are helpful to help you move through this difficult patch, especially if you've got stuck. Put your hand up and say you need help, because it is out there. So thank you, and I think we've got time for talk now, and can perhaps so how do I, that's it, stop sharing.
Yeah, that's it, that's brilliant.
That's it.
That's great. Oh, Carol, that was so good. Thank you so much.
Fantastic.
Fantastic. I mean, I've just learned so much, and I'm going to watch it again, because I'm sure there's stuff that I haven't really taken on board as much as I should have done, because there was so much to listen to, and it's fantastic. Thank you so much.
Oh, well, thank you. I'm glad. Yeah.
So at the moment, there's no questions that have come through on the chat function, but I've actually got a question. Just keep things off. You mentioned in the talk about levels of anxiety sort of 10 years after treatment ends, and how they're still very high for the patient and their partners. How would you go about accessing counselling sort of that far down the line, when most people would assume that you're over it and that you're okay? How would the former patient sort of try and get some help?
I think the first port of call for most people is going to be going to their GP, or if they're still at a follow-up at the hospital, mentioning it at the hospital. I've actually had 2 patients in this last week that I counselled years ago get back in contact, because the general climate of COVID and everything has added to everybody's anxiety and the load that everyone's carrying, and it's tipped some people back into that space. And I've had 2 patients get back in contact, and that's fine. I'm always happy for all patients to get back in contact. It's nice to hear from them when things are going well, and I'm there for them when things are not going well. And yes, and the counselling is available for partners as well as patients. I certainly am happy to counsel partners as well as patients. And if you go to your GP, if you're accessing counselling through your GP, there's no reason why a partner shouldn't get counselling at all. And if your GP doesn't know about the stats on anxiety, then you maybe need to educate your GP, because actually you're the one who's most likely to be anxious 10 years down the line, rather than your partner. And your partner's got a pretty good chance of being anxious, but you're even more anxious. I think to watch people you love suffer is a particular kind of suffering all of its own. Does that answer your question?
Thank you, guys. I was going to ask something just in between other questions. You mentioned is it the rapid eye movement for dealing with trauma?
Yeah.
So we know that trauma post-treatment is a big thing for people, whether that be, going back into the hospital for checkups and scans, or actually sometimes it can be triggered by the smell of an environment that they were in during a period of time of treatment or surgery. You talked about the rapid eye movement. Is that usually the sort of work that you do with patients and families around trauma, or are there other things that people can be doing in their day-to-day lives to try and alleviate those really crippling feelings of fear, I suppose, that are amongst people in their everyday life, and especially going back into hospitals as lots of people have to do? How would you deal with that?
Okay, well, I mean, when trauma happens, especially post-traumatic stress disorder, although there are subclinical levels of trauma that are also really, disabling for people. What happens when you're really traumatized is there's a part of the brain called the hippocampus, and that goes offline. And the hippocampus is involved in learning and memory, and it's also involved in date stamping. So when you have a normal memory, that memory is broken up into constituent bits and stored in the brain, and then when you retrieve it, it's brought together. But trauma memories aren't stored properly. They seem to be whole, and that when a part of that memory, like a smell or some other implicit, you may not even know what it is that's causing it. It might be an implicit thing that you remember rather than remembering explicitly. But some kind of sensory stimulus takes you back into that place. And what happens in post-traumatic stress disorder is that the whole of that memory comes back as if you were reliving it. And I think there are subclinical levels of that where people can have flashbacks at a lower level. And in EMDR, I've only done the first part of the training, and there are 3 parts, so I'm not actually using it with patients yet. And I've let the training slip, actually, because it's been so busy, and it's something I need to get back to doing. But what happens in MDR is you're taught, as you are in relaxation, and to create a safe space. So you, in your mind, you take yourself back to somewhere where you've been happy and you've been safe. Or you might not take yourself back in time, because not everybody has that memory, but you create memory. You go somewhere where you feel safe and you feel happy, and you create it in as much detail as you can. So you not only sort of see it in your mind, you smell it, you possibly taste it, you feel the air on your skin, you notice what time of day or year it is, you listen to what sounds you can hear, and you smell the environment there. And you keep that memory, you sort of access that memory, and you sort of twin it with relaxation. And then when you, and in some forms of relaxation, you might even twin it with, say, a particular holding a pebble or clasping your own hand. So you're twinning all those things together. And then when you're in a situation of anxiety, you can access that memory by grabbing your pebble or twinning your hand and taking yourself back to that place and helping to bring your anxiety down. And there's sort of research to show that anxiety often, if you don't stop it, it just goes up in a big slope. But if you can interrupt that climb with relaxation, maybe you're doing the 4-7-8 breath, maybe you're taking yourself to your safe space. Whatever you're doing, it might be, some people use music, then what you do is you end up with a flight of steps. The anxiety may still rise, but it won't rise as high or as rapidly because you're slowing it down. But anxiety is a fact of life, and it's there, in large part to protect us. Mm-hmm. So you don't want ever not to feel anxiety, but it can become like a runaway truck after cancer, where it just runs amok and it's really destructive.
Thank you.
And so the safe space is what they do in EMDR, and what I do when I've treated patients with trauma is create the safe space, and then instead of MDR, get them to start to recall the memory. And often when people have a trauma memory, there are bits of it they can't recall, it's a bit fractured, the narrative isn't very smooth, and getting people to recall the memory, and as they become distressed, stopping the recall and taking them to the safe space. And you might need to do it many times over many sessions, getting them to go back into the memory and then using the safe space and the breathing to bring down the anxiety until such time as the memory can be stored like a normal memory is stored, instead of as an intact experience.
So interesting.
But EMDR is fascinating. I don't know if anybody's come across it, but basically when you get people to recall the memory, you use the safe space, but you get them to recall the memory while they're also following your finger. And there's something about this left eye movement. And sometimes it's a finger, or some therapists who are really posh have a bar and the light goes up and down the bar at the prescribed speed, and your eyes track that light. And no one understands why, but there's something about tracking that light that helps the brain store the memory. So it's a lot faster than and a lot less painful. And it's particularly good for shame-based memories because you don't actually have to vocalize them. You can, access your memory without sharing it with your therapist and do the light treatment. And it is fascinating. I guess I'll work out why it works one day, but at the moment, people don't know why it works. But it does seem to be very promising for trauma. And there was a real shortage of EMDR therapists, but I think there's an increasing number. So if anyone's, suffering trauma or knows anyone suffering from trauma, EMDR is a really good thing to ask to be referred for.
I suppose it's quite a big label, isn't it? Trauma. It comes in many different forms, and it's good to just say it actually that trauma does come with these types of experiences. Thank you, Carol. That's really interesting.
I like Tracy's. Tracy's just asked how many of us were doing the 4-7-8 breathing when you were talking about it. Well, I certainly was.
I was.
I didn't see that.
It's something that I will certainly do myself. So I think it's such a useful skill to have. Tracy's asked if we can send the slides out. You've got no objection to that, have you, Carol? If we just send the
No,
slides?
of course not. No, fine.
That's no problem. We can do that.
Yeah.
I have another question, but I don't want to take up the forum too much. But please do, butt in if people do have something they want to ask. For people who are going through the thick of it right now and are still in the hospital appointments, going to treatment, getting through surgery, what is your, I suppose, advice for those types of families in terms of psychological support? Obviously, you work at the Royal Orthopaedic in Birmingham, and you work with people right from diagnosis, you say, from when cancer is raised as a possibility. How do people go about accessing it, whilst they are going through it necessarily, in the hospital?
Generally what happens is sometimes people ask if there is a psychological support available and refer themselves. More often staff will notice that they're distressed and ask them if they'd like to see a counsellor.
Okay.
And not everybody that's distressed does want to see a counsellor. Sometimes people just want to chat to a friend or talk to a minister in their faith. It's not for everybody. Everybody's different. But the cancer nurse specialist is like your portal really into all kinds of referrals and signposting, and she'll know a lot.
Thank you.
And there was a chat there. Carolyn, let's have a look. Carrie, what was Carrie saying? I can't see the chat. But not as a good technique. Hi, Carrie. I think if you can switch off, which is like the ultimate form of letting go.
Yeah.
I think that's absolutely brilliant. And I think sometimes people get worried about whether they're in denial, and sometimes being in denial is actually the crutch that you need at a particular moment in time. I think it's not helpful in some situations if the denial carries on against, all evidence to the contrary, and somebody's not willing to look at a situation that's deteriorating. Then that's not helpful. But I think in the short term, denial is often very helpful, and I don't think switching off is a form of denial. I think switching off is a form of being able to let go. And I think that's really helpful.
Yeah, because
I know you're very, sorry?
I have switched off quite a lot, to be honest, with a lot of what's been going on around my illness. And sometimes I wonder if it is, builds up for future problems, just by kind of switching off to them, or if it actually helps you cope. So, I guess that's why I asked the question initially. But so far it seemed to have helped me, to be honest, along with the breathing as well. Because I know when I was in Birmingham, I used to do breathe in for 5, breathe out for 5, and it helped me, 3 weeks in hospital, etc. It helped me get through that completely. So I'm going to try what you recommend on that slide as well, the 4, 7, 8.
Yeah, it's absolutely wonderful that it comes from a very ancient yoga tradition, that breath. And the guy I taught it to recently, who had a small blood bank in years, was totally delighted with it, and it's very good. But no, I think you call it switching off, but you're talking about switching off to worrying about the future, aren't you? You're talking about just being in the present moment. And
yes.
see, I would call that mindfulness, actually, rather than switching off, being able to just be in the moment and, work through your moments, showing up for your life as it unfolds moment by moment, and trusting that if and when anything happens in the future, you'll be able to rise to that challenge or find help to rise to that challenge. And I don't think that's denial at all. I think that's really, really healthy. It's a bit more like, the zebra, really, not torturing yourself with what if thoughts, and being able to live moment by moment. And that's very much what, if you were learning mindfulness meditation, I'd be teaching you to try and achieve, and you're sort of doing it naturally, which is amazing. So I think that's great.
Thank you.
I was just going to say, Carol, actually, that was the thing that really sort of struck a chord with me, because I thought everybody, regardless of what's happened to you in your life, could do with living or trying to live a bit more in the moment, because it's a great way to live. And you're saying mindfulness meditation is the way that you can try and achieve that. And I can't remember, on the slide, did you have any resources for how people can teach themselves mindfulness, or is there anything?
There's a link on the slide to Vidyamal and Birch's Breathworks mindfulness courses, and I also put up the names of the different, the MBSR, which is mindfulness-based stress reduction, with the mindfulness-based cognitive therapy, which is tweaked slightly for people that are suffering from depression. So it's a combination of mindfulness and CBT for depression.
Okay.
And then there's mindfulness-based cognitive therapy for people with cancer, which I think is developed by somebody called Trish Bartley, and that's really lovely. It's like a particularly gentle sort of mindfulness based with cognitive therapy. Always you do, partly what you do is learn to turn towards the difficult and to have some degree of equanimity in that relationship with your difficult, whatever the difficult is for you, because it's different for everybody. But whichever one you choose. I think what I would say is that because mindfulness has become more popular, and I think there was a select committee, there was a report produced by the government a few years ago, and I think Vidyamal and Birch actually gave evidence to that select committee, and they started now to introduce mindfulness in schools, in prisons, where else, in hospitals, and somewhere else. I can't remember, 4 places where they were delivering. I can't remember the 4th one. Anyway, and I know that the American Army teach it to their officers to help them remain cool under fire. I know lawyers use it because it helps with their focus. There's, so many gains from being able to be in the moment, which is something Carrie obviously does naturally. So, but the rest of us are having to struggle to catch up with you, Carrie, and to learn, to just be in the moment more. Because actually, there's a book written by I've forgotten the name now of the chap, but it's called The Power of Now. And basically, he says You know, we can only live in this moment.
Mm.
You know, your breakfast, that's gone. It's back with the pharaohs, and everything else that ever happened in the past, it's gone and finished. The future that you're worrying about may or may not come to pass. And the only time we can ever really live is right here, right now, in this moment. You know, and we're sharing this moment together, and that's very lovely. But how many of us are actually showing up for our moments? How many of us are elsewhere in our head, and we're not actually showing up for our life as it unfolds moment by moment?
Yeah,
I struggle with it myself. My partner says we teach that we most need to learn, and that's certainly true for me.
Yeah,
So.
absolutely. Were there any more questions to put to Carol at this stage? Anybody else? Okay. Should we close there? I think all that's left to say, Carol, is a huge thank you to you for just spending the time to talk through, you know, some really difficult things, but actually making it seem doable for people. So yeah, we're very grateful to you for being here with us. And like we say, if you do have any personal questions or, you know, kind of circumstances that you would like to talk to Carol about, then Jo and I can help you do that. And then the next webinar will be in 2 weeks' time, 2 weeks on Thursday, and it will be, actually you mentioned at the beginning, Carol, about palliative care and kind of readdressing the rhetoric behind that, and actually what it actually is and not what it traditionally used to be. So I think that's a very important topic to discuss.
Yes.
So
who we've got coming? Is it it's Professor Richard Harding, who's the he's the Professor of Palliative Care and Rehabilitation at King's College.
Yeah.
And I think it's something that Louise and I both wanted to bring to the webinars, because as Carol was saying, I think people think of palliative care as being just end of life care, and it encompasses so much more than that. So hopefully that webinar will dispel some of those around it.
Absolutely. But thank you all for joining us, and we'll hopefully see you again soon.
Yes.
Right.
Thank you.
Thank you, guys.
Bye.
Bye. Bye.
Okay. Bye
Take
now.
care. Bye.